Okay, so now we're going to go ahead and talk about increased intracranial pressure, also known as IICP. Okay, so you may say, what is increased intracranial pressure? Well, it is a rise in pressure of the CSF, right, or blood within the skull or the brain, right? So what happened is pretty much there's a whole bunch of pressure, right? A regulation of pressure that occurs naturally, right? And that pressure level, normal levels, you want it to be around 10 to 20, okay? And the brain, according to the book, Brunners and Suddarth, okay, the brain is around 1,400 grams, right? The blood that's in the brain is around 75 mLs, and the CSF is also 75 mLs, which gives an equal combination of a pressure of 10 to 20, okay? So with that said, right, you may say, okay, so if that's the normal pressure, what happens if you have a pressure higher than that? Well, that's exactly what we're going to talk about today is the signs and symptoms, the causes, and the treatments of what happens when you have an increased intracranial pressure. So first off, anything in an increase of pressure in the brain is not going to be a good thing. Why? Well, let's go back to the drawing that I had earlier when I was explaining the brain. Right? So we have our brain here. We have our frontal lobe, parietal lobe, temporal lobe, occipital lobe, the cerebellum, right? Our midbrain, pons, and medulla. These are the main components that I really want to stress about when it comes to the brain, just because the increase in intracranial pressure is going to affect these things that you're going to see in the signs and symptoms in the clinical manifestation, which is also your nursing assessment, right? So what happens here? Okay, so here I have, if you see in blue, that is your CSF, right? And I should draw in red. Let me just get my red marker, right? You may have blood somewhere along the line because, again, you do have blood that needs to get to the brain to give it oxygen and the nutrients that it needs, right? So I have the CSF, and I also have the blood, right? So what happens when I've had brain trauma, right? I have a gunshot wound, or I fell, or something happened where pretty much now there's an increase in fluid, right? Because it can be an increase in CSF, right? I have an increase in fluid. So when that increase in fluid or blood, right? This is my increase, okay? And then of my fluid, whichever one. Once I have that increase, right? It's not like any other place where it's like, okay, it's able to expand. Why? Because in purple, as you can see here, I have my skull, right? And my skull is not as flexible. So it stays just as it is, right? It stays just as it is. So the brain is like a boat, and you have to remember that. The brain is like a boat, right? And it can only expand so much because the skull is there to protect it, and the skull itself is not something that is flexible, right? It's hard, it's rigid, it's a bone, right? And it's there for protection. So when I have this overflow of fluid, whether it's blood or CFF, right, this blood has to go somewhere. And what's happening is it's going to crush or put pressure on the brain tissue that's around those areas, and eventually it has to go somewhere, right? And remember, if you guys remember in anatomy, right, within the skull, there's an opening because the spinal cord has to continue down because this is the spinal cord. There's an opening. That opening is called the foramen magnum, right? And that is the only opening that connects the brain to the spinal cord. So you know what happened is that after you have this increase of pressure, the blood and the CSF is going to build up and eventually it is crushing, literally. And I want you guys to get that picture. It is crushing the brain, right? So my FL, which is my frontal lobe, remember what we talked about earlier, our frontal lobe deals with what? Our rational thinking, our decision making, critical thinking. This is where our personality lies. So if depending on where the bleeding is happening or where the pressure is occurring, it's going to alter different things, right? So I have pushing on the frontal lobe, right? I may have pushing on the occipital lobe. Occipital deals with vision, right? Our eyes, right? that have pushing on the temporal lobe or the parietal lobe, wherever it's pushing, right? It's going to push, and the only exit that the body is able to see is, hey, this hole right here, this foramen ovale, because I cannot expand this way. The only thing I can do is come down this way because this is the only opening. This is the only way out, right? So the brain is pretty much being squished down this area here. And as you can see, you have the midbrain, the pons, and the medulla. All three of these main things that deal with respiratory, blood pressure, heart rate, right? Different functions that are so important and vital to our everyday living gets crushed into this foramen magnum. And when that occurs and the crushing takes place and the brain is literally coming down into this foramen magnum, that is what we call a herniation. So it ultimately, an increased intracranial pressure is going to lead to a herniation. And a herniation is pretty much, like I said, the brain is pushing downward in the foramen magnum, right, which causes damage to the brain. Not only just the brain, but the different components of the brain, right? We have the midbrain, the pons, the medulla, and then ultimately the spinal cord, right? Because all those nerves and all those signals that would transfer down has now been damaged. So literally, that's what I want you guys to think about. When you have a patient who has increased intracranial pressure, think about your brain being evoked, and you have either extra CSF fluid or extra blood, right, wherever it's at, and it's pushing on the brain, all right, and the brain is evoked. So the only exit is this guy right here, the foramen magnum, and literally the brain is being crushed into this area here, okay? Okay, and the brain is being crushed in this area here, okay? So again, you want to prevent this from happening. There's going to be times where it's not preventable, but I'm going to show you along the way certain things that is important to know as a nurse and things to watch out for when it comes to increased intracranial pressure. So I hope that this illustration gives you a good understanding of what intracranial pressure is, all right, and what an increase is going to do to the brain, and what's important to know to help prevent this, or signs and symptoms to see if it's going to get worse. All right, so now I'm going to talk about some of the causes of increased intracranial pressure, okay? So we can have an increase in tissue volume. And how does that happen? Either you can have a mass, right, or neoplasm or some sort, or cerebral edema. And cerebral edema is just pretty much the same edema that you would see in the legs. The only thing is that this edema is happening in the cerebrum, which is the brain, okay? But same concept. So there's an increase in tissue volume, okay? You can also get it from an abscess, right? An abscess is similar to like a mass or so. You do have, sometimes it can be in the capsule, so, right, you have that abscess there, and it can cause swelling in that area, right? And then also, too, it can also cause an infection sometimes when, if it's burst or so, it can cause an infection. All right, so that's another way how you can get into increase intracranial pressure. And then the other two ways I've stated earlier is pretty much by an increase in blood volume and an increase in CSF fluid, right? And you may say, why are you getting an increase in blood volume or CSF fluid? Well, it can be many different ways, and some of the ways can be caused from an obstruction of some sort, right? Deficient absorption, right? Because the CSF and blood gets reabsorbed, and different waste products that comes from the brain, right? It goes into the CSF, and those things get absorbed. And sometimes, you know, there's not a proper absorption, and all that extra fluid that will normally get absorbed is not being absorbed. So now you have an extra increase of CSF fluid, or you can have an overproduction. You have some people, their bodies produce too much CSF fluid, right? And you know, eventually, sometimes it can be fixed with BP shunts and things like that, which I'll talk over another time. But you can have an overproduction, all right? An obstruction can occur. It can be a blockage where there is a blood clot or some sort of hematoma, right? And it causes swelling because now all that extra blood is being backed up. So different things can cause the obstruction, but these are some ways of how you get an increase in blood and CSF, okay? Also, too, right, because there's an obstruction or a blockage of some sort, Eventually, the brain has a lack of O2, and it can also be from the bleeding as well. If you're bleeding out and all of this blood is not going into the vascular spaces, it's going into the tissues or so, there's a lack of O2. And remember, I don't know if you guys remember from anatomy with the respiratory system, remember the O2 goes into the lungs and in exchange it gets CO2, right? But because there is no gas exchange, right, the O2, there's a lack of O2, so now there's a buildup of CO2, right, carbon dioxide that's in the brain, and which are in the vessels, right, in the vascular spaces, right, because there is no gas exchange. So now you're left with hypercapnia, okay, and hypercapnia is the same thing as saying an increase in CO2, all right, that's the correct terminology, hypercapnia. And when you have hypercapnia, an increase in CO2, you have vasodilation, and a decrease in CO2, you have hypocapnia, which gives you vasoconstriction. Now, this is where I say you have the two evils here, right? And the reason why I say that is because you may think, oh, okay, when you're dilated, right, it helps to decrease the pressure. Well, when it comes to the brain, it's a little bit different. When you have vasodilation, it causes more pressure, intracranial pressure. Why? Because now that vessel is dilated, more blood, right, is able to flow through. So now I have more blood going into that area, which causes more swelling, more pressure, right, which is something that we do not want. And then the body, sometimes it may try to compensate, right, and that's why you have that rapid breathing or hyperventilation to kind of blow off some of that CO2. So sometimes as well, when you have hypocapnia, right, you'll start with vasoconstriction, which you're like, okay, that's good, right, because then now you don't have a whole bunch of blood flowing through. You just have a little bit of blood flowing through, but it can't stay for too long. And eventually, what happens is that it ends up dilating, and once it dilates, right, all of that blood goes through. And then again, vasoconstriction also causes pressure on the vessels as well, right, and they eventually gives way. So again, that's why I say you have the two evils here, because at the end of the day, these two things can eventually cause an increase in ICP. Even though the body's trying to compensate, it can still cause an increase because it cannot stay that way for too long. Okay, so these are the different causes that you will see that can occur to increase intracranial pressure. All right. So now we have another player that also is involved, right? We have cerebral perfusion pressure, which is also known as CPP. Now you may say, what is that, right? So cerebral perfusion pressure is pretty much the cerebral blood flow, the pressure of the cerebral blood flow to the brain, right? Which is going to carry oxygen and metabolite, right? And different nutrients to the body, right? It's going to deliver those things. So it's pretty much the pressure that it takes the cerebral blood flow to go to the brain, right? That's pretty much gonna be carrying the oxygen and the metabolite delivery, right? So now you have normal levels, and normal level is pretty much 60 to 100, right? Hyperperfusion is anything greater than 100. Hypoperfusion is within 40 to 60, right? And then you have brain death, which is 0 to 40, all right? And then as you can see here, a cerebral perfusion pressure that is less than 50, right, is irreversible neurological damage, all right? So the goal of the game is pretty much you want to maintain around 70 to 80 according to Brunners and Suddarth. You want to keep between 70 and 80. So we're going to put here, maintain at least 70 to 80. All right, so even though this is the normal levels, a good maintenance is within 70 to 80. All right, you don't want to be too high, you don't want to be too low. Now, here is how you calculate the CPP, because you may say, where are you getting these numbers, right? Where are these numbers coming from? Well, to calculate the CPP, this is how you find it, right? You take the map minus the ICP, which is intracranial pressure, right? And that is going to equal your cerebral perfusion pressure, okay? So this is how you calculate it. And this right here is your normal levels. This is where you kind of want to maintain it. And then this is your brain death. This is important to know, right? This is classified as brain death. And anything less than 50 is irreversible neurological damage. And like I said before, remember, these neurons, right, they do not regenerate like regular cells, like, you know, when you get a cut and your skin is able to rejuvenate itself because it goes to mitosis and the cell is able to, you know, replace itself. When it comes to the neurons, whatever is there, and there is no more. So once they are damaged, there is no coming back or trying to rejuvenate or trying to bring forth those things that were once lost. Okay, once they're gone, they are gone. That's just how the body works. That's how the nervous system works. Those nerves are very, very sensitive, and once they are gone, they are gone. Okay, so just remember that, because I remember seeing this as a test question and back in nursing school, the brain death one, and maybe the calculation. Not too sure, but it's always good to know though. MAP minus ICP equals CPP. Okay? So now we have the clinical manifestations, which is also known as your signs and symptoms, like I said before, which is also known as your nursing assessment. So those of you guys who haven't watched recent videos from before, one thing I always say, you know, try to cluster as much as you possibly can. You know, clinical manifestation is just another word for signs and symptoms. And why not kill two birds with one stone, right? And if you know your signs and symptoms, you know what you need to assess as a nurse, right? Because what you're going to see presented on the patient is what you're assessing as a nurse, okay? So your signs and symptoms is also known as your nursing assessment, all right? So as long as you know that, you can kind of already know what you're going to assess as a nurse, all right? So if you remember one, you remember both. So first up, we're going to talk about Cushing's triad, okay, which is also known as Cushing's triangle or Cushing's response. Either or, I like to remember as the triangle, and I'll explain in just a little bit, okay? So the first thing, because there are three components that make up the Cushing's triad, that's why hence the word triad, right? Triangle, three, okay? You have, the first one is your widening pulse pressure. Now you may say, what is your widening pulse pressure, right? And your widening pulse pressure is pretty much a wide gap between your SBP, which also stands for systolic blood pressure, and your diastolic blood pressure, right? And most of the time you're going to see an elevated systolic blood pressure. So with that said, an example is I have 120 over 40, right? And if you would subtract 120 from 40, that gives you a difference of 80. You see how wide that gap is? Rather than a regular blood pressure that's kind of in between 120 to 180, I mean to 80, sorry, right? And if you would subtract 120 from 80, that's only a difference of 40. So literally this number almost doubles over here with the 120 over 40. So that's what they mean when they say widening pulse pressure, right? So that's your first sign. Your second sign is your bradypnea, okay? And pretty much what that is low respirations, okay? Pnea is for respiration, breathing, and brady is low, okay? So anything less than 12, okay, is considered bradypnea, all right? And that's your second sign that you're going to see with a patient who is exhibiting increased intracranial pressure, right? And then your last but not least is you have your bradycardia, all right? And bradycardia, which is anything that is less than 60, okay? Because your heart rate, your normal heart rate is 60 to 100, and your normal respiration is 12 to 20. All right, so anything less than these numbers is considered brady. So as you can see here, right, where you have the Cushing's triad or Cushing's triangle, whichever one you choose to use, right? I have bradycardia here, and I have bradypnea here, right? So as you can see, I have the two bases at the bottom, right? Because they're both low, right? So they're both at the bottom. And then the only thing that is high is my blood pressure, right? This stands for blood pressure. HTN stands for blood pressure, okay? And what's going to happen is I'm going to have increased systolic blood pressure. So that I put that at the top, so that way when you connect them together, what do you get? You get your triangle. So that can kind of help you remember, hey, this is the Cushing's triad, the Cushing's triangle, right? Two things at the bottom because they're both low, so they are my basis for my triangle. And then the only thing that is high is the hypertension, the increased systolic blood pressure. All right? And when you see that the body is doing this, right, this is the body's last effort in trying to maintain cerebral perfusion. And why is that so important? Why? Because the blood it has oxygen, it provides nutrients, it provides everything that keeps us living and breathing and thriving, right? And anytime there is a threat to that, right, the body is going to do everything in its might to try to perfuse, to try to get all of that blood to circulate throughout the body, especially within the brain, right, because the brain plays such a vital part in our lives. And this is the last effort that the body is trying to do to overcome the pressure and to still try to bring nutrients to the body. Okay, so when you see the cushions triad, try to remember this little triangle here, all right, and you'll see the blood pressure will start to creep up. Okay, it may even say 180, and you may see 50 over here. It all depends on the patient, but try to remember that widening pulse pressure, that gap in between. All right. All right. So we're going to continue on with the signs and symptoms. And again, you have the early signs, okay, and then you have the late signs. So right now, we're going to talk about early signs, and you have 4 main groups. I like to think about it in 4 main groups, because if you don't, then you can kind of think and get overwhelmed that, oh my gosh, this is so much stuff to remember. But if you can break it down into 4 different groups, that kind of helps. At least it helped me when I had to study this topic, okay? So the 4 different groups, okay, is you have the level of consciousness. That's 1. You have pupillary dysfunction, motor impairment, and body temperature. So you can simply remember that as, right, mental status, right? You can remember that as eyes, right? Movement, because, right, motor is all about movement, and then body temperature. So I have 4 different groups, right? And I'm going to have early signs for each of them, and I'm going to have late signs for each of them. All right, so as you can see, early signs are pretty much things that are happening in the early stage. So these are things that you kind of want to catch on to that are very, very important to kind of prevent or prolong the late signs from occurring or happening as quickly. Okay, because remember, at the end of the day, you don't want the brain to crush, right? Like I said earlier, increased intracranial pressure is pretty much pressure that's eventually going to crush the brain, because the brain, the skull is like a vault, right? It's capsulated, all right? So first thing up is going to be level of consciousness. And with the level of consciousness, right, the patient is going to exhibit signs of confusion, restlessness, right, because of a lack of perfusion to the brain, right, lethargy, which is also known as weak, being very, very, very weak, okay, and then finally they're going to be disoriented times 3. They're not going to know who they are, they're not going to know where they are, they're not going to know the time, right? So it happens like this in that particular order, okay? So it happens first with confusion, then restlessness, then lethargy, and finally they're disoriented completely. All right? And you may say, why is that? As you guys can remember from the illustration that I showed you with the brain, right? It's crushing those different areas. So remember, this is my frontal area, right? This is where I'm able to rationalize, I'm able to think, I'm able to, know who I am, my personality, right? My critical thinking. If this is being destroyed or crushed, right, in some type of way, and those nerves are not able to regenerate, right, whatever damage it's causing, it's going to leave me being confused, restless, lethargic, and disoriented, all right? And again, you want to, pick up on these signs, so that way you can kind of call the doctor and let them know, say, hey, the patient first came in, he was fine, all of a sudden now he's confused. They may want to go ahead and do another CT scan, they may want to go ahead and do an MRI, depending on what the doctor orders will be the next step. But you kind of want to be on guard, be on alert, so that way you can kind of catch these things before it evolves into something worse. So now we're going to talk about the next thing here, which we have is pupillary dysfunction. All right, so this is the next thing here that we're going to talk about, right? Pupillary dysfunction. So with pupillary dysfunction, pupillary is just another way to just say we're talking about the eyes, okay? Which we're talking about mainly the pupils, okay? So the pupils is going to be sluggish or fixed, right, when you shine the light. And then you have either blurry vision or double vision at times. And then you will have an ipsilateral side dysfunction, okay? And ipsilateral just pretty much means the same side dysfunction is what is happening here. All right. So now when you're doing your neurological assessments and your checks, right, and you're checking the eye, right, one of the main things you want to do is you want to have your pen light and you want to shine the light. So normally, this is what our eyes look like without the light, right? They may be 3 mm, and once you shine the pupils are going to constrict, right? That is the natural way of how our body functions, how it works. Now, with a patient who is having or experiencing ICP, right, increased ICP, it may be sluggish, and what it means to pretty much mean sluggish is that this is normal, this is where you want to be, and this happens within seconds of that, right? What happens is there is a delay, right, to get to this point. And it's pretty much if this is your pupil, it kind of goes very slow, which they consider that to be sluggish. Or it can be fixed. And what I mean by that is that here, right, instead of it constricting, even without light, this is what it looks like, right? And with the light, okay, it still looks the same, all right? I got one bigger than the other, all right? It still looks the same. And that's what it means when they say it is fixed. So that means even when you shine the light or without the light, it looks completely the same. There's nothing happening there, all right? And this is what you will see in the early signs, right, of pupillary dysfunction. All right, so now we're going to talk about motor impairment, right? So we're down to 3 now, right? So we're on motor impairment, and the things that you want to watch out as early signs, right? You have hemiparesis, which is pretty much to be weak on one side. You have hemiplegia, which is to be paralyzed on one side, right? And don't get this confused with paraplegic, okay? Because paraplegic, yes, it is half, right? Because hemi means half, right? That's why you have on one side, but it's not divided as far as this way. It's divided as far as this way. All right, so it's not horizontal, it is a vertical, right? So when they say hemiplegic, right, it's paralyzed on one side, they're talking about like this coming all the way down. You split yourself, right, mid-sagittal, right? And you was to split that whole side, whichever side is affected, that whole side is paralyzed, but this side is free, right? Not this way. Because some people may think, oh, hemiplegia, yeah, the legs are not good, but the upper body is. No, that's paraplegic. Okay, and I know, you know, sometimes you're learning and, you know, you're coming into nursing school for the very first time, you're getting familiar with these medical terms and things like that, and you think hemi half, and you may want to cut the body, you know, horizontally, or transverse, right, or transverse, but that's not what this means, okay? Half meaning vertical, right, mid-sagittal plane, all right? So you're going to see it on one side, and then finally you have contralateral side, which is also known as the opposite. Contra meaning against, okay? Right? That's why you have contra indicated, against, right? So contralateral is the opposite side. And what it means by the opposite side is pretty much, let's say you have the brain damage on the right side of the brain, or let's say someone has a stroke, right? And it's the right side of the brain, but the left side is affected, right? That's the opposite, right? So that's what it means when it says contralateral. And I know earlier you guys saw when I had the pupillary dysfunction, it had ipsilateral, which that's the same side. So if the right side of the brain is not working, then the right side of the body is not working. That's what it means when it says ipsilateral. Ipsilateral side, okay? So contralateral is the opposite, right? And ipsi is the same. And hemiplegic, we know, right? We're talking about a mid-sagittal plane, right? So half of your body is not going to function the proper way, right? And then you have hemiparesis, which is just weakness on one side. And the last of the main 4 groups is the body temperature, okay? And with the body temperature is pretty much going to stay in normal ranges. So in the early stage, you're not going to really see much of a change in the body temperature. It is going to be in normal ranges. So I wrote down here for you what normal ranges are, and pretty much if you're looking at Fahrenheit is between 97 to 99, okay? And of course, your average, which is your average temperature, which most people are normally going to be at, is 98.6, okay? And I just pretty much just transfer that into Celsius, because remember, now that we are in the medical field, they go by the metric system, so you may just see Celsius. Again, when you are in certain hospitals, the temperature probe does have the option of changing Celsius to Fahrenheit, so don't worry too much if you guys are like, oh my gosh, I'm not good with Celsius. You know, you do have the option of switching it back to Fahrenheit, so that way you can kind of see what it is. All right. So Celsius will be 36.1 degrees to 37.2 degrees, and pretty much the average is 37, which pretty much, if you was to change this would be 98.6 in Fahrenheit. Okay, so this is this number, this is that number, and this is this number. Okay, I just put out both for you so you see Fahrenheit and the Celsius. All right, but you are going to be in a normal range. Okay, so now we're going to talk about the late signs, right? And this is when the condition has progressed and gotten to a later stage where it is more at risk of having worsening effects. Okay. So now you're going to have a decreased level of consciousness, right? And there's a possibility of being comatose, all right? And, you know, we explained before, comatose is pretty much no responsiveness, right, to anything and no movement. So even to pain, right? And even when you're stimulating them for pain, there's certain things that you can do. You can do a sternal rub, which is pretty much a very hard, aggressive rub to see if they would wake up or be arousable, or if they would, wake up to the pain of that. You can pinch their fingers or their toes, or you can squeeze their hands or their feet, right? And if you see that as you're squeezing them very, very hard to kind of stimulate that painful stimuli, and there is nothing going on, you already kind of can tell that they're in a comatose state, especially if they are not responding, okay? The next thing you have is pupillary dysfunction. Okay, so we're just going back over the 4 main groups again, all right? So I like to do it that way just because if you can see the 4 early stages and you see the 4 late stages, then you can see how it is progressing and getting worse along the way, all right? We have pupillary edema, which is pretty much swelling of the optic disc. And with that, I drew a little illustration down here so you can kind of see exactly what's going on. And as you can see with the eyes, there's different things that can occur, all right? As we said before, in the early stage, you may see it may be sluggish or fixed. As it progresses, the eye itself, the pupil, can be blown. And when they say blown, they're pretty much saying that it has dilated so there is no return. It's not responding. There is nothing going on. It is just shot, right? And as you can see here, I try to draw little vessels so that way you guys can see that the vessels in the eyes are very, very small. And surrounding it is the buildup of pressure, whether it's from the blood, whether it's from CSF fluid, whatever is causing the pressure, right? There's a pressure against these small vessels, right? And they can only take so much, right? That eventually the eyes are not functioning the way that they're supposed to, which you're seeing the outer appearance of what the pupils are looking like, all right? Based on the fact that the optic disc is swelling and is distorted. Okay, so here, as you can see, right, this pupil and this pupil are different sizes. So don't be taken off guard, because there are some times where you will have patients that one side is worse than the other. And again, it all goes back on what side in the brain is affected, which we're talking about. If it's ipsilateral, and that means, if they say that it's ipsilateral, that means that the side that is being affected, which let's say it's this side, which is the right side, that is the right side of the brain that is also being affected, whether that they have the lesion, whether that's the area that has the bleeding, whether that's the area that has the CF fluid, okay, if it's the same side. And if it's contralateral, then then it's the opposite side. So let's say that the lesion or the bleeding is occurring here, but the other side is being affected, okay? So, but if it's ipsilateral, you'll see same side distortation, okay? And then here, this is another option that you can possibly have, right? And this is where both of the eyes are progressing at the same time, which pretty much lets you know that it's, somewhere, maybe it's happening in the middle of the brain that this is occurring, right? And both eyes will be dilating. And that's one thing that occurs with pupillary dysfunction, is that the eyes are dilating, they're not responding to the light, right? And sometimes both of them can be blown. All right, and this is when you know that you're getting to the point of herniation. All right, so all of these signs being put together is going to let you know that this patient is getting closer and closer to the herniation. Okay. So the late stages for motor dysfunction, right, is going to be decorticate, decerebrate, and flaccidity, and it's going to happen in that order, okay? This is bad, this is worse, this is the worst, okay? Or bad, baddest, and then worse, all right? How about that, since baddest is a word. So with the decorticate, right, the hands are going to be turned inward. Remember the trick that I told you about? The decorticate has an I in it, the I in inward, right? So they're going to be turned inward. All right, decerebrate have an E, right? External rotation, right? They're going to be rotated outward, decerebrate. And in flaccidity, there is no muscle tone, right? There is a decrease in tendon reflexes, right? It's or almost completely absent. That is paralysis, all right? They are paralyzed. There is nothing there. You will see the foot drop, right? There will be no tone whatsoever, all right? And then you have your body temperature. And your body temperature, remember before there wasn't a change, it was just kind of normal. Well, now the body temperature is going to play a part. Why? All right, and it's going to be elevated. Why is that? I don't know if you guys remember, but in anatomy, there's a place in the brain that where you have the hypothalamus, right? And the hypothalamus is somewhere close to the third ventricle and between the fourth ventricle, right? So now that the temperature is going to play a part, the temperature is going to rise because the body has no way of having thermal regulation, right? So it's going to have an increase in the temperature, and it's because of the hypothalamus. So as you can see, right, the brain is being crushed, and everything is going in or escaping through this hole called the foramen magnum, which is in the skull, right? It's going down that hole, and as you can see, where there was no problem with body temperature, there is a problem with body temperature. Why? Because now the hypothalamus is now also being affected. It is being crushed. So as you can see, just kind of think of that picture in your head of that brain, right? That is being compressed with a whole bunch of fluid, right? And all that pressure is being there, and all you have is just this little hole, this tiny hole to alleviate all of that pressure. So you have your brain literally trying to squeeze in that area, right? And with the brain squeezing in that area, it has now gotten to the point where it has been passed. It passed the medulla. It's past the pons, right? It's probably past or getting ready to pass the midbrain, right? So all of those things are being crushed to the point where it is now affecting the hypothalamus, which is why you can kind of see that these are the late signs of ICP, because again, it is getting worse and worse to the point where the body is not able to regulate and do the things that it normally would be doing. All right, so these are the late signs of the main four groups, right? Which we have the main four groups listed here again. So aside from the four main groups of the clinical manifestations of the late and early stages, right? You also have just other signs and symptoms as far as headache, right? And the headache gets worse in the mornings or when you're trying to change or reposition them, right? And then you also have vomiting. What type of vomiting is projectile vomiting? Projectile vomiting is pretty much a vomiting where you just have this urge to vomit, right? Without having to be nauseated, right? There's no urge for you to, feel as if like you need to go to vomit. You just all of a sudden just go ahead suddenly and you just vomit, and you vomit profusely, right? So these are some other clinical manifestations or signs and symptoms that can occur, right? And then ultimately you have brain herniation, which is the very last stage of the complication, right? And with this, right, this is from a result of untreated ICP, all right, increase intracranial pressure, which ultimately leads to death. So your whole goal as a nurse, right, your mission is to pretty much prevent brain herniation, right? And how do you do that? By being the eyes and ears for the patient. And you do that by pretty much listening to their concerns when they say that they're having a headache and they're vomiting, but they don't have the urge. They didn't feel nauseated, right? When you're doing your level of consciousness and you're asking, okay, do you know who you are? Can you tell me your first name, your last name? Can you tell me what today's date? Can you tell me, what year is it? Can you tell me where you are? And they're telling you things that are not making sense, right? You have to be your patient's advocate and know that, hey, something is not right. And if you can find that out in the early stage, the earlier the better, because then it can help prevent some of these things. Now, I'm not saying that you're going to be able to prevent all of this from happening, because there are going to be times where the patient may come in already at the late stages, and there's nothing that you can do, right? And it's because, I remember a patient that I've had, and this was a sad case. I won't say the name because I don't want to violate any HIPAA or anything like that, but the patient had a very, very high blood pressure and a bleeding in the brain. And, the patient only complained of having a headache. So the family member just gave Tylenol thinking that it would go away, that it would feel better, but the headache just only got worse, right? And 3 hours had already passed by at this time. So they finally said, you know what? They went back up into the room to check, and the patient was passed out, right? Unresponsive, not able to talk or say anything. So that's what brought them into the hospital. When they did the CT, right, they realized that he was already too far gone. There was nothing that they could have done because he was already going through the herniation process. So, like I said, there are going to be times where you can be that superhero for that patient, and you will be able to, step in and intervene at the right time to help save a patient's life. But then there are cases where the patient is already too far gone, and they already started the process of herniation. Okay, and when that is happening, whether they came in on the late stages or they came in on the early stages, but it has now progressed, right? Because hours are passing by, and time is your enemy here. When it comes to increased intracranial pressure, time is your enemy, because it can happen very, 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 very fast. Okay, for this patient, it only took him 3 hours, right? And in those 3 hours, that she thought he was gonna feel better by giving him Tylenol, he was already herniating. All right, so again, brain herniation is the worst thing that can possibly happen, because eventually it is going to lead to death, because once the brain is being crushed and it is now squeezing through this small hole, right, those nerves can no longer be regenerated, right? And remember, think about the things that are encompassed in the brain, right? You have the midbrain, you have the pons, you have the medulla, right? All these things regulate blood pressure, right? Which is why you have the widening pulse pressure. You have heart rate, because the medulla deals with the heart rate. It deals with respiratory, right? You're regulating respiratory responses and things like that. And most of the time, you see these patients that are going to end up being on ventilators, which is pretty much life support, which the outside community knows it as life support. But if you're a healthcare professional, or you're in the medical field, you know it to be a mechanical ventilator, right? And most of these patients are going to end up being on these type of support, because they are not able to regulate their own respirations. Okay, so think about these things. Have that picture in your head about the brain and different areas of the brain and what those areas are responsible for, because when you start to see the signs and symptoms, you can kind of get a better picture. Okay, that makes sense. They're going to have problems with the eyes, because why? We have the occipital lobe, right? And the occipital lobe deals with vision. It makes sense, if they're going to be confused, because we have the frontal lobe, right? That makes sense. It makes sense that, they're going to have problems with respirations or regulating body temperature. So think about those different compartments in the brain that have those regular functions. Okay, and I'll try my best to put in the description box more information about the different areas, like the pons and the medulla, and different aspects of the brain, what they're responsible for, what they do. So also, again, if you don't see the information that you want in the videos, I also put extra information within the description box. So remember to check the description box. Sometimes I even have links to certain information that would kind of benefit you guys if you guys want to know more information about something that I didn't touch too much about in the video. So again, also check out the description box. All right, so now we're going to go ahead and continue on with, now that we have this patient, what are we going to do as a nurse, right? So the next thing that the nurse needs to do is pretty much figure out what the doctor wants to have done as far as testing. right? So these are the different types of the diagnostic testing that you can do for a patient who has increased intracranial pressure. So first off is you have your CT scan, which CT scan pretty much stands for computerized tomography, which is an X-ray with computer processing, okay? So it's almost as if you were going for an X-ray. The only thing is that this one is more of a high-tech X-ray, all right? It sees in one-dimensional pictures. It's very cheap. Well, not as cheap as an X-ray, but it's cheaper than an MRI for a fact, okay? And you must keep still. This one takes about 15-20 minutes or so, depending if the patient is to have contrast or without contrast. But again, they must keep still, okay? And of course, this is considered a non-invasive procedure, so you don't need consent. At least for a CT scan, you don't need a consent, all right? And pretty much, that is your CT scan. MRI, okay? An MRI is a magnetic resonance imaging, all right? This is your heavy duty to see more, all right? So it takes several pictures from different viewpoints, right, of different parts of the tissues and different areas, right? It sees more than just a one-dimensional picture, all right? Which is why it costs more, right? Than a CT, and you must keep still as well. This test is a little bit longer. Sometimes it can be 45 minutes to an hour, all right? With this test being said, there are certain procedures and precautions that you want to take into consideration, all right? You must follow your hospital policy. I know for us, we have to get consent for the MRI as well as do a check-off list for the MRI. And with that check-off list, one of the biggest thing is you must remove all metals, not some metals, not partial metals, all metals, jewelry, okay, pacemakers, and even things that you probably won't even think about, like hairpins, right? People have hairpins all the time, and you may say, oh, I'm not thinking about that. Well, you want to think about those things, right? Any earrings, any hairpins. If the patient has a pacemaker, right? That's very important. Most of the time, if they have a pacemaker, sometimes they are opt out from this decision because a pacemaker is metal. Again, another thing too is sometimes you get tattoos, right? You may think, of what does a tattoo has to do with anything? Well, I don't know if you guys know those tattoos that kind of like shimmer or shines or things like that. Well, they have metal in them, right? Metallic metal in them, and you're not able to go into the machine. So sometimes you want to be careful. Yeah, it may look nice, and you may say, oh, it shimmers, but then now you may not be able to take a test that can help to save your life. So again, just remember, these are things that you want to take into consideration and things that you want to think about asking the patient as well. Even though they have a check-off list, sometimes you may overlook the fact of their tattoo, and you may want to know, hey, does this shimmer? Does it have any metallics in there? Or sometimes you may get a tattoo yourself, and you want to know exactly what type of ink is in there. Okay, you don't want to just take any type of ink. Know what ink is in there. All right. So you want to remove all metals. Now back to the pacemaker. There are some pacemakers now that are compatible. So you want to check to make sure that they are compatible. And with that, at least for our hospital, we call Medtronics, which are the ones who pretty much deals with the pacemaker, and maybe the owner or the company of the pacemaker. We call them to verify if the pacemaker is compatible with the MRI machine or if it's not. Okay, and if it is, then Medtronic will come in and they will ask for the cardiology to have the orders written of what settings the pacemaker is in, just in case they go into the machine and the machine kind of wipes away those settings. The Medtronic people can go ahead and put those settings back in for the patient. Okay, so again, you want to make sure that you have your consents for this. Sometimes it can be with contrast as well. You want to make sure the patient not claustrophobic. A lot of times they complain of that, right? We have medications for that. So just because you're claustrophobic doesn't mean that she doesn't get to do the MRI, right? Because if it can save your life, why wouldn't you? So you want to make sure that, you have different diseases checked off from their list to make sure that they're clear and that they're able to go into the MRI. And you want to make sure that you're also giving the patient their safety as well, okay? And again, here, I've put it in red because this is very, very, very important. These are questions that I like to ask a lot, okay? No lumbar puncture. Again, no lumbar puncture. Why is that, right? Because lumbar puncture puts pressure on the spinal cord as it is, which is going to increase the intracranial pressure, which is only going to what? Further the damage of the neurological system. Okay, so you don't want that. There is no lumbar puncture. This is a question they love to ask about lumbar puncture. They also like to ask questions about temperature with the hypothalamus. They like to ask questions with that. Flaccidity. Okay, so these are some things that you kind of want to make sure you brush up on, because these are your heavy hitter questions. Probably, again, maybe the MRI, making sure that they have no metal, that they're going in safe, right? If they have a pacemaker, you want to make sure it's compatible. But if it's not compatible, then if they have a pacemaker, that's a no deal, okay? And that is pretty much the diagnostic testing that you're going to have, right? And it's, of course, it's going to be of the brain. And the doctor would then go ahead and visualize and see exactly what's happening, where the damage is taking place, and from there, write in orders of what they want to have done. Okay, so now that you've done your diagnostic testing, right, and you see that this patient does have intracranial pressure and that there's a bleed or a CSF or there's a lesion, whatever the case may be, right, what's the next step? Well, we want to monitor, right? And why do we want to monitor? We want to monitor to make sure that we get normal ranges, or the ranges are, at a therapeutic level, or we can see exactly how high it's going, so that way we can see what procedures or what interventions we need to intervene and do right away, right? We also want to make sure we try to preserve the brain function as much as possible, right? And we also want to prevent any secondary brain damage. Now, what I mean by secondary brain damage is pretty much, right, I didn't have any problems with my eyes, but all of a sudden now, because I have increased intracranial pressure, which also push pressure in the occipital lobe, which then eventually caused me to have blurry vision or, vision loss, right? That's a secondary problem to the brain damage, right? Because that's not what I came in for, right? So that's just one example, right? So that's the reason why you want to monitor, right? Now, I put here an asterisk, okay? Nurses should be able to identify the problem, all right, which is what, NCLEX require us to know, which is why we are discussing the different signs and symptoms, right? So we can identify the problem, what's going on. We get that clear picture of what's going on in the brain, right? But ultimately, the MD, medical doctor, right, is to fix the problem, all right? So remember, we always need an order. So even though you may know what to do, right, we can't do anything unless we have gotten orders, okay? So you always want to make sure, and to protect your license as well, always make sure you call and you have gotten orders, okay, before you just go ahead and just do certain things. You want to get orders. So our job is to identify the problem and to call and to alert the doctor. Their job is to fix the problem, all right? And I know sometimes we like to be fixers, and we may want to jump ahead and do something, but again, you don't want that to cost you your license, because if there's no order, you cannot do it, right? So now we have different types of ICP monitors, right? So yeah, we want to monitor it, but what are we going to monitor it with? So we have different devices here that I got from the Brunners and Suddarth book, right? I guess these are the most popular ones. They have the ventriculostomy, which I have dealt with, okay? Out of everything on this list, I want to say I have dealt with a ventriculostomy. I have seen the subarachnoid screws or bolts, right? But it's very rare that I have to deal with them, okay? Epidural monitor, okay? You have a fiber optic monitor, and then you have the IICP, okay, or Leacox catheter system, okay? And this system can also assist with monitoring the cerebral perfusion pressure. Remember the CPP that we was talking about? And if you guys can remember, how did we calculate that? MAP minus ICP equals CPP, all right? So these are some of the monitors that you can see here, and I'm going to put in the description box a little description about each one. Very rare, though, do they talk about any of this during testing or any questions, but I'll just put information there just so you guys can have a basis or a well-rounded, teaching of the different monitors, so that way, just in case you may have those professors that may throw, an oddball question in there about it, you can kind of be prepared because you kind of know some information about it. But again, I remember studying them, and I didn't really see any of those type of questions on it. It was mainly about the signs and symptoms, the late and the early, okay? But again, we want to monitor, monitor, monitor. So now we're getting closer and closer and closer what we're going to do for a patient who has intracranial pressure, right? So now we're going to talk about the treatments. So first up, we're going to talk about medication. Now normally I put the medication on a separate video, but the medications that are used is not really that much options. They mainly do the surgical procedures, which I'll get into in just a bit. But some of the medication is osmotic diuretics, and pretty much the only osmotic diuretic is mannitol. That's the only one in that class, right? So mannitol is used to help reduce the cerebral edema, right? And you want to know why? Well, the action is it's pretty much it draws water from the tissues, including the brain and the cerebral spinal fluid, right, into the interstitial fluid and the plasma. So pretty much the swelling that's going on in the brain, this medication is going to pretty much pull all of that fluid that's there and pull it into the vascular spaces, right, to kind of help alleviate some of that swelling. Okay, mannitol, when you think of mannitol, think of sugar. Okay, it's a sugary substance, right, and it's like a crystalloid or so, and pretty much it is given to patients who have intracranial pressure, right, or swelling of some sort, and pretty much what it does, it pulls, right, it pulls those fluids, right, from the interstitial, from the tissues, right, into the vascular spaces. All right. The next thing you can use a loop diuretic. And if you notice, diuretic, they're both doing the same thing, right? So the mechanism of action is going to be the same thing. The only thing is that where this medication is working in the vascular spaces, okay? Where it doesn't always just target the brain. This one in particular, the osmotic diuretic, targets the brain a lot. And the loop diuretic can be more generalized, okay? So it brings all those fluid out into the urine. So again, with these medication, one thing you want to watch out for is dehydration. Okay, dehydration, because it's pulling fluid into the vascular spaces. Again, then that fluid is then now transferred into the kidneys where it dumps out as urine, right? So you're going to be dumping a whole lot of urine. And that's one thing with diuretics. Diuretics, think of these are your water pill, right? The patient knows it as, oh, I need my water pill, right? And they call it water pill because it kind of makes them go constantly, and they're putting out a lot of output, okay? So one thing you want to think about is dehydration, okay? That can occur. Another thing is corticosteroids, right? And we know corticosteroids help with inflammation, right? It's an anti-inflammatory medication, right? An example here, we have dexamethasone, which is known as Decadrone, right? And the action is to reduce the edema that is surrounding the tumor or the cerebral edema, right? But the only time you're not going to use this, right, is if the patient is having these symptoms because of trauma, all right? It's not going to be that beneficial, but you do want to use it for anti-inflammatory reasons to kind of help with the swelling, and again, it's going to reduce that edema, that swelling that is around those tissues that is causing the pressure, okay? So it helps to alleviate some of the pressure. And one thing that you want to be sure with this medication is it causes an increase in blood glucose. So what do you want to be checking? You want to be checking your blood glucose levels, whether it's every 4 hours, every 6 hours, you know, whatever the doctor has ordered. But that's one thing with this medication that you want to watch out for is the blood sugar, all right? And with mannitol, again, you can think of this as a sugary substance, okay? And that's how the fluid is able to leave from the brain into the vascular spaces, okay? Because once remember the thing of osmosis, right? The mechanism of osmosis, right? Water wants to travel, right, where there's more concentrated substances, right? So if you have all of that in the bloodstream, right, the fluid that's in here is going to go ahead and try to migrate into my vascular space, and right, my interstitial fluid and my plasma is going to want to travel into those areas, and eventually that extra fluid that is traveling into my vessels now, because this sugary substance is there, right, and it pulls the fluid into those spaces, then gets absorbed from my kidneys and is able to be excreted out. All right, so just think about this is how these medications are working. So now we're going to go ahead and talk about the intracranial surgeries, okay? And the first off is the burr holes. And burr holes is pretty much a procedure where literally there are boring holes, right, into the skull. So they're drilling holes into the skull to help drain and evacuate the hematoma, right? There are circular openings that are made by either a hand drill, right, or automatic chronotome, which is pretty much a drill that stops once the bone has been penetrated. So sometimes I think maybe this would maybe be the better option, just so you don't have to worry about manually doing it and you damage parts of the brain. Okay, so at least you know that this automatically stops once it has reached the bone. Okay, and it can also be used for shunting procedures, right? It can also be used for removing abscess, making a bone flap, right? And determining the size of the ventricles and cerebral swelling or injury, right? Which in this case, it may be because of injury, right? Which is why it's causing intracranial pressure. So here I drew a little picture so you can kind of see exactly what's going on. This is supposed to be the skull, and you're drilling holes into the skull. And with you drilling holes into the skull, remember, like I said before, the brain is like a vault, right, because of the skull. But if you bore holes, right, instead of just only having that hole of the foramen magnum to have all those things come down from, right, I have these little holes, right, and what happens is it helps to drain some of those, the bleeding or buildup of fluid, right, and what it does, it helps to alleviate the pressure, all right. So this is one technique that they will use to help to decrease intracranial pressure. And of course, this is going to be a sterile technique. The dressing and everything else is going to be sterile, and you're going to follow the doctor's orders on far as dressing change. Remember, you do not change the initial dressing. That is the doctor's job to change the initial dressing. Okay, and most of the time it happens after post-op day 2. Or if it's saturated, but for the most part, it's post-op day 2 is when they start doing the dressing change, and the initial dressing should be changed by the physician. Of course, it's sterile technique, and however he wants to drain or keep the system draining, either he wants to connect the bag or whatever device that he wants to connect to this, or he may want it to just drain freely, right? Or he may put a JP drain, whichever he chooses to do. A Jackson Pratt, okay, it's JP, Jackson Pratt, just in case you guys don't know, right? And he may want to hook it up to this. So it all depends, but again, this procedure is to alleviate. And you can see that it's alleviating. I try to draw the little blood, letting you know that the blood is coming through, right? So that helps to alleviate some of the pressure. The next approach is a craniotomy, okay? And a craniotomy is pretty much the opening of the skull surgically, right? And you do this to gain access to the intracranial structures, okay? And what you're pretty much doing is you're creating a bony flap by cutting at the skull, right? And it is used to remove possible tumors, right? To relieve increased intracranial pressure, to evacuate blood clots, and to control a hemorrhage, right? If you are bleeding, all right, it's used to help control a hemorrhage. So there's 3 different approaches that you can do. They have the supratentorial approach of the craniotomy, and pretty much supra means above, and the tentorium is pretty much placed within the brain, the skull, right? And pretty much, if you put it together, above the tentorium. So that's pretty much the approaches that they're cutting away above the tentorium. Okay, the next one is infratentorium, right? Infra, think of inferior, right? Below, right? So it's below the tentorium. And then the last one is transsphenoidal craniotomy, and pretty much this one is through the mouth and nasal sinuses, right? And with this procedure, of course, your dressing change, you want to have your nasal packing, right? And you want to monitor vision care because you are going up in this region here, okay? So you always have the possibility of damage towards the vision area, right? Because it's so close together. So you want to be monitoring vision changes and, just providing vision care to the patient, right? With the transsphenoidal approach, you want to avoid sneezing and coughing. Why? Because that's just only going to increase the intracranial pressure. Again, of course, sometimes it's unpreventable, but you want to minimize it as much as possible, and maybe not as rough, but trying to do it as soft as you possibly can, okay? to try to alleviate some of that pressure. And then you want to recommend them drinking through a straw, okay? So that's one thing that you want to do to kind of help alleviate, because you don't want them chugging back, right? So just a little sips here and there, all right? It's fine. So this is the second surgical approach that they can do, is a craniotomy, and it's pretty much just an open area, flat, okay, that they just kind of just open just a slide, okay, so that's why they say think of it like a flap, right? It goes up and down. It's still there, but it's just a little flap opening, so that way that pressure is alleviated, okay? So I'm going to go ahead and just draw a little illustration here in my skull. Okay, so don't judge. All right, so this is my flap, all right? And pretty much I just cut just a little piece, okay? So that way it can kind of alleviate. So you're gonna see here and here that the bleeding may drain out, which helps to alleviate that pressure, which is a good thing, right? Or sometimes it may not be the bleeding at all. Sometimes it could be that it was a tumor that caused it. So of course, if they're cutting away at the bone and they're able to expose the brain, and they are able to, get to a place where they're able to get the tumor and it's safely able to be removed without causing any damage, then of course the neurosurgeon would then go ahead and remove it. And then from there, of course, that is going to alleviate the pressure, because the very thing that was causing the pressure is no longer there anymore, okay? But again, there are times where the tumor is inoperable and they're not able to get to the area, so you have ways of having it drained, okay? Or maybe it's the CSF fluid, right? That's also draining from there, but this is what it's going to look like. It's like a flap, okay? And of course, they're going to have a dressing, sterile dressing, to prevent any infections. Of course, that the doctor is supposed to take off the initial dressing, and anything after that, you will go ahead and follow through with his orders on how he wants you to cleanse the wound and how he wants you to treat the wound, okay, and to dress it. So again, most of the time it happens post-op day 2, but depending on how saturated it is, they may have to do it sooner than that. But again, this is the technique of the craniotomy. So now we have another procedure called a craniectomy, okay? Now, I know it sounds very similar to cranioptomy, but this is craniectomy. Anytime you see ectomy, that means removal of, right? And it's removal of the cranium, which is the part of the skull. So it's an incision of a portion of the skull, right? And then you're going to do a cranioplasty repair of the cranial defect using a plastic or metal plate. All right, and pretty much what that is I draw here a little skull, right? And then I have here a piece of the skull taken away, right? And this purplish thing here is supposed to be like the actual brain. Like I'm trying to show you that you remove it, okay? And this is what's going to be different from the craniotomy. Craniotomy is just, you're just making a flap, right? A bony flap, where here you actually are taking away that area, okay? So you still may see the scalp, so you don't see exactly the brain itself. It's not just completely exposed. You're still going to see the scalp. Not the scalp, but there may be the meninges, right? Which you have the dura mater, the pia mater, and the arachnoid mater, right? All there to help protect. So it's not just the actual brain itself, okay? It does have a layer on it, okay? And pretty much you remove this flap. Before, they used to take the flap and they used to insert it into your abdomen or so, and pretty much they would do that to kind of keep it sterile, and it will kind of stay nourished from your body. But then sometimes your body rejects it, right? And sometimes you may think that, why would it reject it? It belongs to it, right? But that's how it is sometimes, right? Your body rejects its own thing. So very rarely you see those still occurring, where they will insert it into the abdomen and leave it there for a while. Now you may see they may put it in like a freezer or so, very sterile freezer, and they'll keep it there for some time until the pressure is alleviated or so, and then they may go ahead and surgically put it back. Or if they do not do that, then this is where the cranioplasty comes into part, where they may do a repair and they may use either a plastic or a metal plate to kind of cover and put over it, okay? And sometimes you miss some of that skull. So again, You just want to make sure that you're monitoring the dressing. Most of the time it's post-op day 2. And of course, the doctor is responsible for taking off the initial dressing. And of course, again, it is going to alleviate the pressure, because remember, that brain is like a vault. And once I remove part of the skull or so, it helps to alleviate some of that pressure, so that way it's not crushing into the foramen magnum, okay? And this is one of the procedures that they do in surgery. And now we're going to talk about post-operative care, okay? And post-operative care is pretty much what are you going to do after the procedure, all right? And of course, with any procedure, you're always at risk for infection. So one thing that you want to do, you want to be proactive. You don't want to be reactive, right? You want to go ahead and give antibiotics, right? Knowing that, hey, they've probably been exposed to environment, right? They don't have that protection there as they normally should have. So you want to give antibiotics. You're also going to give Pepsid. Pepsid is a medication to help prevent stomach ulcers, or what it does, it helps to alleviate especially stress ulcers that sometimes you can get because of high volume of stress. I'm not saying that you're stressed out, but the stress that your body is going through, especially with the increased intracranial pressure, you can have ulcers, which is a secondary problem that you don't want to occur. So most of the hospitals have a protocol where they are having, Pepsid or some type of HH blocker or a PPI, proton pump inhibitor, right, that they will give to prevent the ulcers from occurring, okay? You're also going to have pain management, okay, because this patient just had surgery. Of course, we can suspect some type of pain. So the medication that they may prescribe, you have Percocet, which Percocet is pretty much Tylenol 3, okay? It has some traces of the hydrocodone in it, and that's what kind of makes it more potent than the Tylenol itself. Okay, you may have Ultram, which is, I think, is Toradol, the other name for it, and then you have Tylenol. And as you can see, these are not really your heavy hitters. Why? Because when this patient comes back, you're probably, most likely, you're going to have neuro checks. Okay, so this patient is probably going to be in the ICU. These are patients that I would see, at least in neuro ICU. We also have a medical ICU and a cardiac ICU, but this patient is going to be in your neuro ICU. All right. And with this said, there are going to be neuro checks. Okay, so you can have neuro checks every 1 hour, every 2 hours, every 4 hours. If they're just coming out of surgery, it may be every 1 hour. And once there has not been any changes or so, then the doctor may go ahead and say, okay, I want you to go ahead and monitor every 2 hours, okay? Until they've come to a point where it's like, okay, they're stable, they're doing a little bit better or so, and then, or there's no changes, right? Because it don't always have to be that they're getting better, but if there's no changes, all right, they may change it to every 4 hours, depending, okay? Until they get transferred up to the floor. So, as you can see, back to the pain medication, I'm not really giving the heavy hitters because I want to see exactly what's going on with your brain function. So if I give you Dilaudid or fentanyl, right, or morphine, right, those big heavy hitters, right, those medications automatically make you drowsy, maybe make you lethargic or so, and then I can't assess neurologically what's going on with you. So I don't want to give you too much pain medication where I can't see neurologically what's the baseline status, right? So I want to give you some medication to alleviate, but not completely knock you out, okay? So I just wanted to get rid of the pain, but for you to still be alert. So that's why you will see, your Percocet, which is your Tylenol 3, Ultram, and Tylenol, okay? Depending if the pain is not being alleviated, they may give fentanyl or morphine, but it's very, very low doses. They're going to try to use these medications first before they get to that point, okay? You also have your anti-seizure medication. For some reason, once you have surgery in the brain or so, you always have a risk of having seizures, okay? So, again, you want to be proactive and want to kind of attack it before the seizures happen. So you want to go ahead and give anti-seizure medication. Now, there are times, because I've had patients where they've had these procedures done and they're seizing, okay? So then you can give Ativan, you can give Dilantin. A lot of times we give Keppra, 500 milligrams, and then of course if they're seizing or so, they may get a 750 milligram or maybe even 1,000, depending on what the doctor wants to prescribe. They also have valproic acid, which is Depakote. Okay, that's another anti-seizure medication. So I'll definitely explain that when I get to the seizure section of it. Okay. And then you have transcranial Dopplers. You may say, what is that? That is a test that they do to see exactly the brain activity and what is going on, see if there's any vasospasm. So that's the main reason why they do this test. They're trying to monitor for vasospasm. And I've had patients who would have this done every day, at least for 7 days or so. All right, so even though it's negative day 1, day 2, day 3, day 4, it doesn't matter. They're going to still go ahead and do those transcranial Dopplers because you just never know. They may do have the vasospasms, okay? And these patients are going to be on Nemotop, okay? Nemotop is an anti-vasospasm. It helps with that. And you'll see these patients on this medication around the clock, okay? Nemotop for this one, okay, to help prevent the vasospasms. Again, I have the dressing changes that I told you about, that I mentioned. You want to do temperature management, right? You want to make sure that they're not having any fever, right? Because that can be a sign of an infection some way, somehow, right? You want to make sure that it's okay. These patients are probably going to have a Foley catheter or so to monitor input-output, especially if they're on a ventilator. They're automatically going to get a Foley because they're not aware to let you know when they have to go to the bathroom. You don't want them to have any wetness or so, because moist areas cause great risk for having skin breakdown and then pressure ulcers and stuff like that. So you don't want to have that. So if the patient is on a vent, you want to make sure you're doing vent care and vent management. And what I mean by vent management is pretty much your suctioning, that you are doing the oral secretion with the chlorhexidine medication that they give you. It's almost like a mouthwash or so, and you kind of swab it into their mouth, and you do this trach, the trach if they're on the trach by that time, or you suction them through the ETT too, okay? And you would also check for the settings as well. You don't have to worry too much about the settings because you have respiratory therapists who are in charge of those things. But again, we are responsible for suctioning and mouth care for the patient. So you want to make sure you have that. They may go ahead and do labs, right? Because certain medications like the Dilantin or so, they have toxicity levels. So you want to make sure that they are in therapeutic ranges. So again, you probably are going to do blood work, all right? And you're going to do some labs. And then make sure what's important is positioning, right? Because these patients are not going to be able to move for themselves, or they may have a very hard time moving, or they may have the hemopharesis or hemiplegia, right? And they're not able to help move. So you're going to help to, your job is to help assist, right? Changing them or turning them every 2 hours to make sure that they're not developing those pressure ulcers, right? And that their skin is staying intact. And again, blood glucose monitoring, right? Especially if they're on medication like corticosteroids to help with the inflammation and things like that. You want to make sure that you're monitoring the blood glucose level, okay? Because those type of medication does cause an increase in the blood sugar, all right? And these are the post-operative care that you want to be doing. I know it's a mouthful, I know it's a lot, but again, you only get better with repetition, and going over them. But I do want you guys to see the story, okay? If I'm coming from surgery, I have risk for infection, so I know I need antibiotics. The patient is going to be in pain. I'm dealing with the brain, right? So I have risk for seizures, right? I have risk for vasospasms, right? If I'm dealing with the brain, I want to make sure that I'm doing my neural assessment more often than normal, right? I want to make sure that I have my dressing changed, right? We talked about signs and symptoms of knowing different things, right? Temperature management. We want to make sure they're not having any infection. Foley care, right? Vent care, lab. So these things are going to come natural to you eventually over some time. But again, try to create that story and know why you're doing what you're doing. And last but not least, we have nursing interventions and nursing care. All right, so these are the things that you want to make sure that you're mindful of while you're dealing with this type of patient, okay? So you want to make sure, number one, right? And I'm going to highlight that because it is very, very, very important. They like to ask a lot of these type of questions, right? Is maintain a patent airway, all right? Remember, a breathing patient is an alive patient. A non-breathing patient is no patient at all. All right, so the main thing we want to make sure we want to maintain a patent airway. Another thing that we want to do is that we want to monitor ABGs, and ABGs pretty much stands for arterial blood gas, and I'll do a lecture about arterial blood gas and different pH levels and the scales and knowing how to differentiate metabolic acidosis and things like that, respiratory alkalosis or respiratory acidosis, okay, based on the results that you'll get from your ABGs, okay, because they can tell you a lot about what's going on with the patient, okay. With that said, all right, you want to have support for the family members, right? Because they're going to be dealing with this, especially if the person is declining, the patient that you have is declining, right? There is irreversible neuro damage, right? And they don't want to be left on a life support, you know, dealing with the loss of a loved one. You know, they may have anger, they may have denial, you know, the 5 different stages of Ross, right? They may experience those things. So you kind of want to just give support, you know, make sure that you're always, you know, giving information to the patient, that you're involving them in the care, you know, you're giving them support, right? Another thing, these patients are mostly going to be on mechanical ventilators, okay, with sedation of some sort, and the medication that they're normally on, at least within my unit or so, it's the Diprovan, which Diprovan is propofol, okay, and a lot of you guys may know this medication because this was the medication, yes, that Michael Jackson was on when he passed away. And I'm not saying that, oh, this medication is a bad medication. It's not. It is administered according to your weight, okay, and maybe for Michael Jackson, the person who was giving it or so did not, you know, take that into consideration. They probably just gave the dose to him. And from there, you know, if anything is given and is not regulated or so, there's always a chance for an overdose. All right, but Diprovan is one of the main medications that they do give for sedation medication, okay? And they give it to you only to sedate you. So Michael Jackson should never even had access to this medication at all. All right, so don't want you guys to be afraid of this medication, okay? It is a good medication. It almost looks like milk, right? It has that whitish consistency to it, and again, it acts very, very fast. Okay, it leaves the body very, very fast. It has a short lifespan within the body. Okay, so sometimes some patients do well on it. Sometimes they need a combination of the Diprovan and fentanyl. Okay, so sometimes you'll see that, and the reason for this is one, right? You want to decrease the metabolic cellular demand, right? You don't want the patients getting up and trying to move and different things like that. You want healing. So you get healing with rest, right? Also for the patient's comfort, right? Because those tubes going down your throat is not as comfortable. Or if they're trach, right? They're not as comfortable, especially when it's hooked up to the vent and they may want to reach for certain things, right? So you don't want them to cause any harm for themselves. So you want to give them comfort, and then also prevent self-extubation, okay? And that has happened where patients would just literally pull the tube out, right? And now they're in respiratory distress because they need the breathing tube, but because it's so uncomfortable or they don't know where they are or they're confused, they just pull on it. So sometimes these medications, these sedation medications help not just only to decrease the metabolic cellular demand, but also to kind of keep them comfortable and to protect themselves from harm, right? So while they're on the vent, and not even just on the vent, but just in general, there are some measurements here that you want to pay attention to. You have PAO, which is pretty much partial pressure of oxygen, and you want to maintain that around 100. Okay, 80 to 100 is the kind of the leeway, but you want to lean it more towards the 100 side. Okay. The next thing you have is you have PaCO2, which is pretty much partial pressure of carbon dioxide, and you want to maintain that greater than 30. Okay, and the range is pretty much 35 to 45, and you want to make sure that it's greater than 30. Whatever you do, you want to make sure it's greater than 30. And again, you have your respiratory therapist here to make those adjustments in the vent settings if they need to kind of get this level to be at a therapeutic level. Okay. The next thing you want to do as a nurse, you want to elevate the head of the bed. All right, so HOB means head of the bed. So if you see me put that, that's exactly what that means, elevate the head of the bed. All right, and you want to elevate it no more than 30 degrees. 30 degrees or sometimes flat, depending on how the doctor wants the patient to be, right? He may put in orders, keep patient flat for the next 4 hours or 6 hours or however many hours, right? So you want to follow the doctor's orders on that. but most of the time they are no higher than 30, right? So if you have a patient who's on burr hole, craniotomy, craniectomy, right, or just have increased ICP, no higher than 30 degrees, all right? Anything higher than that, you cause more pressure, because why? When they go up, right, gravity helps to pull down more, right? And what's causing the herniation, right? The fact that the brain is coming down. So you don't want to sit up the bed too high, because then now gravity is there to kind of help pull it down faster. So no more than 30 degrees. Sometimes it's less than 30, but no more than 30, all right? Another thing, right? You want to monitor bladder and bowel functions. And again, there are going to be different organs that are going to be affected. Why? Because the midbrain, the pons, and the medulla also regulates different other functions of the brain. I mean, of the body, right? So you want to make sure that you're monitoring bladder and bowel function, right? So you want to check your input and your output. And these patients, you're probably going to go ahead and restrict their fluids. Why? Because they already have so much fluid going on in the places that don't need fluids, right? That you want to restrict their fluids. But again, also, if they're getting the mannitol, if they're getting the Lasix, right, and they're dehydrated, then of course, based on the doctor's orders and based on what the blood work is showing, you may want to give some fluid replacement. So again, that is all based on what's going on with the patient. Okay, this is not just an all here, and this is what you do. Again, there are going to be some leeways. You are going to have to use your critical thinking skills to know exactly when to differentiate the different times of when am I going to restrict fluid, when am I going to give fluid, all right? And it's all based on lab work and things like that, all right, and what the doctor ultimately wants to do. And then you want to provide a quiet environment, all right? Why? Because you want the patient to rest, right? And the way how you rest is when you're in a quiet environment. Sometimes when the patient is in an environment where it's so loud and so chaotic, the blood pressure does tend to go up. The patient gets agitated. Even though they're not able to say anything, they are agitated, and it disrupts the healing process, okay? And I have seen that happen verbatim. Patients on the vent and things like that, and the patient family members are getting rowdy inside the room. Some of them are crying, some of them are weeping, some of them are arguing, right? And the patient blood pressure was just going up, and I had to tell them, to lower your voices, try their best not to, agitate the patient so he can, have the healing process. And some of them even, was able to leave the room or so, and as soon as that happened, I want to say 15 minutes later, the blood pressure went back down. Okay, so these things do happen, and you want to promote a quiet environment so that way they can heal a lot better because they're able to rest. All right, there's less stimulation. All right, you don't want to stimulate them, right, because the body is still working. So you want to make sure that there's not that much stimulation. Now, the next thing you want to do is you want to monitor the insertion site, right? Because remember we talked about the ICP monitoring, right? You want to make sure you're checking the site, make sure there's no infection, that the screws are not rusting or anything like that, right? You want to make sure that you're using aseptic technique to clean these areas or so. But one thing you do not want to do, you not want to tighten any screws or do any of that, right? Because that's not our job. Our job is to just make sure we're monitoring, make sure it's clean. If it's rusted or so, we want to make sure we call the doctor and let them know, say, hey, this is what's going on with the patient. The ICP monitoring device, has leaking around it, or it has, pus, or different things that may show you signs and symptoms of an infection or things like that, right? So we do not want to touch the monitors on our own. That's why we have the doctors. Okay. So the next thing that we want to do is pretty much use aseptic technique, okay, for all of these things that we're doing that is going to require us to make sure that we're keeping everything sterile and clean, because again, we are dealing with the brain. So again, with the screws, you want to make sure that you are checking for the leaks and things like that. So if you like this video, please give it a thumbs up. If you have any questions or any comments, please write it in the comment section below. Again, also check the description box for a whole bunch of other information that you can get based on this topic. And again, if you like this video, please share it with someone, please subscribe, and let us all encourage each other as we're moving on and we're trying to understand